here. And I would really like to start out by recognizing Julio's energy and dynamism in getting us all here, and perseverance, and despite broken ribs, etc., he would still get us here, and he would get us here in bigger numbers than last year. And I think you are, Julio, thank you. You and your team, you are obviously a driving force in the conversations we're going to have over the next few days. So this is very much appreciated. I would like to share with you over the next 10-15 minutes, and I know we are a little bit behind time already, the WHO perspective and highlight some of the work that we are currently doing related to the prevention benefits of ARVs. Over the next couple of days, we will largely focus on a single biomedical intervention. And this clearly, building on what others have already said, should not diminish the importance of other, both biomedical and behavioral interventions, including male circumcision, microbicides, PrEP, condoms, or ultimately, hopefully, vaccines. We all know that to be successful, these interventions work best as a part of a comprehensive approach, even though, quite honestly, we still need to do some more, and a lot of important work is currently ongoing to see what the optimal combinations are in given situations and how far they can take us. Progress in scaling up access to ART has been remarkable over the last few years, and we have seen similar slides by Eric. The estimated treatment gap decreased from 97% in 2003 to about 50% of those with CD4 below 350 by end 2010. In other words, about 1/2 of the people living with HIV are immunosuppressed and would likely die within a few years if they are not able to access treatment. It is clear we will, collectively, need to scale up efforts to reach our universal access target of 15 million in 2015. And in doing so, we will have a significant prevention gain already. In addition to the treatment gap, there's also a major prevention gap, with 2.7 million new infections in 2010 alone. The bottom line here is that everybody who is HIV positive today, sooner or later, eventually, will require ART to survive. For every person initiating ORT, there are 2.5 new infections. And it is obvious that, at least in the foreseeable future, until a vaccine hopefully will become available, ARVs will have a critical role to play as part of the prevention response. As we all know, science has provided us with important new evidence, and the landscape is rapidly evolving. I'm not going to go into this in detail, as Carl has been talking about this already. The slide simply tries to illustrate key scientific articles ranging from Julio's prescient 2006 Lancet article to one of the CROI highlights, at least what I believe one of the CROI highlights was of this year, and that was Tanz's talk from KwaZulu-Natal showing decrease in individual risk seen with increasing ART coverage. And there are more studies being done. Thanks to the help of many of you in the room, WHO recently published a review of the 50+ ongoing and planned research studies. We are quite surprised, positively surprised actually, by the variety and number of research studies, and of course are looking forward to see how they will inform global policy and guideline development. The important opportunity, as well as the challenge we are currently facing, is how can ARVs be most strategically and effectively used in a public health approach? Public health approach meaning that effective quality interventions should be accessible by the largest number, ideally all, those who need it and benefit from it. Quite obviously, strategic decisions are normally made in resource-constrained environments. So program planners are currently being faced by very important questions. And I just listed 5 of them here. 1, what is the magnitude of the ART prevention benefit in the local epidemiologic context? in my local epidemiology context? How can results be translated into effective programs at scale and at what additional costs? In which settings and for what populations will ART have the greatest impact? And what's the best mix of interventions to optimize impact, again, in my situation? And what are the best ways to deliver and also to achieve retention? So these are all very challenging, very difficult questions. WHO is holding in the week after next, actually, a consultation, which we call Strategic Use of ARVs #2, to address some of those issues that should influence our global guidance that we're in the process of developing. As you all know, WHO has focused on developing the public health use of ART beginning with 3x5, and by more recently reconceptualizing the public health utility of ART as both treatment and prevention. We see this as part of a continuum and are committed to redefining the public health approach to ART so that it includes both the individual and community impact. Over the last years, WHO's focus has ranged from early modeling work to more recently making the strategic use of ARVs and TasP in that context a flagship of our efforts. So currently, what are the three focus areas of our work? We focus on three things. First, the obvious one, norms and standards. Standards for ARV use that would also address the use of ARVs for prevention, of course. Secondly, guidance that will inform programmatic and operational decisions to answer the questions more or less from the previous slide. And third, and probably equally important, metrics to define indicators and methods for monitoring and evaluation of the impact of TasP. Let me start with priority area 1, normative work. On this slide, you see in blue existing ARV guidelines, and in red, the roadmap for the future and what we are currently working on. Yellow circles are in areas with greatest TasP relevance. In essence, we have decided to move from a silo approach towards a consolidated approach to guide the strategic use of ARVs. Consolidation in three aspects. First, addressing different age groups and populations, children, adolescents, adults, older adults, men, women, pregnant women, key populations. Then, consolidating clinical, operational, and programmatic aspects, the what and the how. And thirdly, to address both the use of ARVs for individual treatment as well as prevention, the what for what rather. Several colleagues here in the room were part of an advisory group that met last November to develop this roadmap. In brief, in the first half of 2013, we plan to publish this consolidated set of guidelines for the treatment and prevention of HIV and TB. It will be informed through a systematic evidence review, the great process that I think you're all familiar with. To keep up with new evidence, we will subsequently develop a 2015 version and likely move towards annual updates from there onward. You will also note that in 2012, we are releasing a number of specific TasP-related guidance and updates, which I will discuss in more detail in the following slide, and Eric has already quite extensively alluded to them. The documents in white have been released already. Those in yellow are for release in the immediate future. To highlight, or the highlight of this list is the release just last week of our first formal TasP recommendation in the context of couples testing and counseling guidelines. And it has had a bit of a long gestation period, but we are still very glad that it's out. While our 2012 WHO HIV-TB collaborative policy did not make a formal recommendation, it does discuss the potential of early ART to prevent TB. We have also just released, already alluded to, a programmatic update for PMTCT that supports the eventual move to option B and B+. We plan to release a TasP technical and programmatic update, a position paper in essence, shortly, within the next couple of weeks. WHO is also doing significant work, and I would like to mention that, in the area of pre-exposure prophylaxis. We are currently reviewing the evidence both in MSM and serodiscordant couples. We will release a rapid advice document in June, which will recommend demonstration projects in these two populations. This slide features our recently released couples testing guidelines and ART for serodiscordant couples. It strongly recommends couples counseling and offering ART for the HIV-positive partner in serodiscordant couples. Here, the PMTCT programmatic update. It is in the context of elimination of new pediatric infections, of course. It suggests consideration of initiating lifelong ART in pregnant women regardless of CD4 count, referred to as option B+. It builds on the compelling arguments for considering this option, combining various benefits, both for the mother, for the child, as well as her partner, specifically in the case of serodiscordancy. Another very important issue is to what extent findings from HTPN 052 can be extrapolated to other populations, specifically key populations such as MSM, sex workers, and IDUs, and also to other modes, obviously linked to that, modes of transmission, specifically anal intercourse. WHO conducted a consultation to look into the latter issue. On this slide, you see the recently published MSM guidelines, Men Who Have Sex with Men guidelines, which discuss the effect of ART as prevention in receptive and insertive anal intercourse. It concludes that observational data and modeling are somewhat inconclusive and asks for more research on combination prevention. The second priority work stream related to TasP is to inform operational and programmatic decisions in a number of areas. This work is carried out largely under the umbrella of the Treatment 2.0 initiative and focuses on 5 pillars. These are not specific to TasP, but most relevant also for TasP. And we will have a separate session on that, I believe, tomorrow afternoon and discuss it in much more detail. Just to quickly highlight the pillars, as 1, optimizing treatment regimens, 2, the use of point of care and other simplified lab technologies, which will permit a more effective diagnosis, ART initiation, and obviously also patient monitoring. And we are not only talking about CD4, but also viral load, obviously, cost reductions, and then the improvement of delivery systems, quite important. And this will obviously include also work on retention. Then the involvement of community in service delivery and support. Work is currently taking place in all 5 pillars. UNAIDS convenes around the 2 white ones, 3 and 5, and WHO convenes and leads in the yellow areas, 1, 2, and 4. But again, we will hear much more tomorrow. In that broader context of Treatment 2.0, we also focused on describing and working on addressing the programmatic and operational considerations specifically challenging to TasP. And there are a number of those listed on this slide, and I'm afraid we don't have enough time to discuss them now, but obviously there will be quite a number of sessions over the next 2 days that will illustrate them in more detail. It can be expected that ART as prevention would substantially reduce new infection also in concentrated epidemics, up to the degree that we talk about elimination there. There are many questions, however, that need to still be answered and better understood, such as how to best implement earlier ART in key populations, what needs to be done differently to achieve high levels of effectiveness in serodiscordant couples, and what would be the best approaches of HIV testing and earlier ART in these settings. Implementation research will help answer many of these questions. And just last month, in collaboration with CDC and NIH and other stakeholders, WHO convened country representatives from 5 Asian countries up there, Thailand, Indonesia, Cambodia, Vietnam, and China, to discuss TasP implementation and research in that context. The slide summarizes plans in these countries, and we most certainly will hear more in some of the presentations over the next few days. The third area and last area of WHO's TasP work is measurement. WHO has initiated work on developing guidance for the metrics for TasP. And here we see the classic case detection and treatment cascade, actually shaped as an onion. And the goal will be to ensure that we increase knowledge of HIV status from less than 50% through various means and through different testing approaches, including community-based testing and eventually self-testing, hopefully, to measure progress along the cascade and ultimately the impact on the prevention effect of ART. Metrics should build on existing M&E approaches, obviously, and focus on a few simple measures that will highlight the proportion of diagnosed, proportion in ART, and ultimately those that are virally suppressed. So let me conclude. We have the evidence that ART has considerable benefits both for treatment of and in the prevention of HIV and TB. Scaling up of ART programs in itself has demonstrated important impact on reducing risk and HIV transmission. ART needs to be seen as a key element of combination prevention with a view to ending the HIV epidemic. From WHO side, we will work with countries and partners to identify best ways to accelerate and optimize treatment programs according to the current eligibility threshold, mainly through the Treatment 2.0 initiative. In addition, we will give highest priority to identifying best options and opportunities for further maximizing the prevention benefit of ART. Focus over the foreseeable future will be on specific populations where prevention impact in given settings is expected to be greatest. And here we have the natural candidates: serodiscordant partners, I'm not calling them couples, partners, pregnant women, and key populations. WHO will issue 2013 consolidated pragmatic and operational guidance and necessary updates in the interim between now and then. We are looking, of course, forward to working with all of you over the next year and years and really share your excitement and commitment and determination to move this forward and taking the elimination approach as something very seriously. I would really like to just end by recognizing and acknowledging colleagues in my own team, specifically Ruben Granich, who has been a most adamant pusher in our department on this area of treatment and prevention, has also helped me with my slides. He and Ying Rouleau, who were part of the scientific committee, Rachel Bagale, who has taken the lead on the couples guidelines, and Nathan Schaefer on the PMTCT update. Thank you very much.